we have some questions here. And I'll start with one and any of you guys can answer. I don't know if these microphones are all live. But this is one that comes up often. I see a lot of patients who have been treated with botulinum toxins, and they say, Botox doesn't work for me. What's your approach to dealing with those folks? Charlie?
So it's pretty much what I said. I say, let me have one shot at it. And I study them, and I come up with a pattern that I think is going to be most efficacious. My experience has been that most of the folks that have had botulinum toxin injections that come to me and say, I've been to see 5, 6, 7, 8 people, they've been seeing people who don't do a lot of blepharospasm, and they don't think very hard about what they're doing. So they're seeing people who do cosmetic Botox, or they're seeing people who do other kinds of movement disorders and don't think very much about the eye. And they may not be managing the dry eye issue, which can overcome the Botox effect, because then you have to give too much Botox and your dry eye is worse, and then a bigger problem. So I think the answer is try a more thoughtful approach, and I find the videos so helpful. The videos and the daily logs, really helpful to me to maximize my treatment. And as a result of thinking about these things a little bit differently, I've found that I'm doing myectomies much less frequently. It's not perfect. I mean, I have plenty of patients that have to come in and get their injections every month, but it's better than they were doing before. And I also found the zinc to be amazing. We stopped the study because we had one gal who was driving to Houston from Oklahoma to get her shots. She'd been to see 7, 8 people, and they hadn't been able to help her out. And we injected her, and she was at least able to walk around her house. And we put her on the zinc supplement, and she came in and she said, I don't care what you gave me, whether it was placebo or some magic pill or fairy dust, but for the first time in 7 years, not only did she drive, but she drove herself from Oklahoma. And I said, well, we have to break the study and see what it was we gave you. And so that's what broke the study. So it can be very helpful for some people. And it's what I said before. Everybody is different, and you have to think about the problem in a multifactorial way and try something maybe a little bit different, a little bit new. Do you have any comments, Andy?
No, I agree. I think everybody's different, and I think your idea of videos is really, really good. I haven't done that before, but seeing how your pattern actually works on the individual patient, and everybody injects a little differently. And I usually, if somebody says Botox doesn't work on me, I usually say, let me give it a try first and see.
The only thing I was going to add to that is that I think it's nice when you bring in your outside records, because I found that many times the prior injections that didn't work, sometimes the provider actually didn't even inject the eyelid. And so, that's a surprise to me. And then sometimes they're also, someone's pointing and saying that was the problem in their case. And sometimes they're using very small doses. And again, I suspect that their concern is that they don't do it very much around the eyelids, and they're very concerned about inducing droopy lid or something. So it's really helpful to bring in those old records so that we can learn from what's been done previously.
All right, there's a couple questions about the DBS. And I think this is a good way, this is a good starter one. If a MAGE patient wants to see if they qualify for DBS, where do they go, and does insurance cover it?
So it depends on the center, where you live in the country, because there's only a small number, relatively small number, a small number for sure that you want to go to be evaluated to have it done. There are a lot of places where people may do it, but you want to make sure you're at a center that is a center of expertise of deep brain stimulation, that has experts in dystonia and movement disorders, who has neurosurgeons. They're stereotactically trained. There are like weekend courses where neurosurgeons can just do this, and my previous position was at the University of Utah. I developed their deep brain stimulation program, and there was a lot of wild, wild west out there, and where things are not placed correctly. And this is brain surgery, or they're not programmed correctly, and people can be very much harmed. So the key thing is to do your homework on the center. How many cases have they done? What is their complication rate? What is their success rate? So here at the University of Minnesota, we have a multidisciplinary center. We had one at the University of Utah. It now is not really there anymore. University of California, San Francisco. There are several in New York City, Cleveland Clinic, Boston, Beth Israel, MGH.
Perhaps you could tell the BRF.
Yes.
That you would recommend, and then they could get the recommendations from them.
Absolutely. So, so go to the foundation. The foundation can give you recommendations of the center near you.
Insurance coverage.
Insurance. So insurance, typically we can get that approved for most people aside from Medicaid, because as I mentioned, it's FDA approved for a segmental dystonia. And typically when we would consider it, it would be, people also have cervical dystonia, and it's approved for that as well. But based on strict interpretation of the FDA, it would be approved. However, insurance can decide anything they want, all right? So they can play tricks, and so, you know, we do the best. Most places don't allow you to even come in the operating room before it's been pre-approved, but there's a disclaimer in every pre-approval that doesn't mean they'll pay for it, and that's true. But in the large majority of cases, we haven't seen it.
And then this is a good follow-up question, and I know there's been some questions in the Blepharospasm newsletter about this, about magnetic DBS for treatment of blepharospasm. Can you talk about that just for a minute?
Yeah, so basically transcranial magnetic stimulation, or transcranial current stimulation. So that has been explored, starting to be explored, and we have smaller effect sizes so far. It's been most studied by actually Dr. Hallett at the NIH. The effect sizes seem to be smaller. That's been looked at in more people with isolated blepharospasm than deep brain stimulation has. We don't understand why people respond or don't. It may be because of our ability to map and understanding what networks we have access to from the external approach. But I imagine that over the next decade or so, that's going to dramatically improve with our brain mapping and understanding the connections in the brain. So I think that's a to be continued.
And then a couple questions on surgery for Ali. After the surgery, will the eyes close properly to sleep, or do they have to be taped closed to sleep? And I guess as a corollary, just some of the other side effects or complications possible from eyelid myectomy surgery.
So that's a great question. So I'm going to limit this to the limited myectomy because I don't know that there's many people doing the full myectomy anymore. With the limited myectomy, there still is a squeezing muscle around the eyelid, and you still will require botulinum toxin. I think, without botulinum toxin, the eyelid will close after surgery. We always have to be, whether a person has blepharospasm or not, we have to be cognizant of how much skin we leave behind, how much soft tissue we leave behind. Some people always come back and say, I still have some droopy skin, I still have some fullness there. And you show them when they close their eyes, that all smoothens out. So an over-aggressive surgeon may remove too much skin, and that's something you don't want. Worsening the dry eye is something you absolutely want to avoid. In regards to the risks of eyelid surgery, the other risks are usually pretty rare. Things like, any surgery, we always talk about infection, bleeding, that kind of stuff. Thankfully, that's really rare with eyelid surgery. But getting back to will the eyelids close, the one thing that occasionally comes up is, we're resetting the height of the eyelid, and we try to be as accurate as possible, but even 2 millimeters of asymmetry between the eyes can be noticeable, and sometimes patients will want a small revision. But our goal is definitely to be able to allow you to continue to close your eyes. I think the one situation where it can get a little tricky is with that silicone sling that I showed for the Apraxia cases. Occasionally we'd have to loosen that a little bit if the eyelid isn't closing completely. But eyelid closure is crucial.
All right, good. And then a couple questions about apraxia. I'll start with Colin. Is apraxia of eyelids not truly blepharospasm? And is it possible to have apraxia and blepharospasm at the same time?
They're very, very interconnected. So I would say it's very common to see patients that have both blepharospasm and apraxia of eyelid opening. The follow-up to that, is it possible? You know, we always have these sort of general guidelines in medicine, and then there's a million exceptions. So it's absolutely possible to have apraxia of eyelid opening without blepharospasm. But I think that the overwhelming majority of patients have both, and it just makes sense that if you have a component of blepharospasm and you are constantly blinking, that the apraxia is also more of a problem. Because if you didn't have the blepharospasm, then once you mechanically lift the lid, then you'd be fine, right? But it's that constant squeezing, then you have to mechanically elevate the lid. And so it's the combination that makes things really difficult. And I found those patients are more challenging to treat with Botox than other patients. And there are some tricks to where to inject the Botox that might make it more effective, but I still find it more challenging to treat.
And then you kind of got my tail end. I was going to have you pass it to Charlie and talk about how you treat patients with apraxia, specifically with the botulinum toxins.
So the muscle, the orbicularis muscle, which is a muscle that closes the eyelid, goes all the way from the eyelash to the eyebrow. And different parts of that muscle do different things. The part of the muscle that has a normal blink is different from the part of the muscle that allows you to squeeze so you don't get soap in your eye in the shower. The part that allows the normal blink is the part that I think is most involved in the pseudoapraxia, and that's just right down by the eyelashes. And you can inject that area and knock out that muscle, but then you knock out the normal blink. And so it's much more difficult to give enough Botox or botulinum toxin, whichever one you're going to use, to stop that spasm and still allow the eye to blink and close normally. And so those are the really challenging patients that have that muscle particularly involved. And what I will frequently do is really concentrate my toxin in that area. So I will maybe 2, 3, 4 times the concentration that I use other parts in the eyelid. That way I can put a very high dose with very low volume. And the reason you want a low volume is the more volume you have, the more that toxin will spread. And if it spreads too high, it gets the muscle that raises the eyelid that we were talking about before. So you're trying to do what was talked about before, decrease the closing and allow the opening to occur. And sometimes I will do a myectomy where I take out just that muscle that's by the eyelashes. Now you don't have a normal blink. You don't have pseudoapraxia, but you don't have a normal blink. And then you have to forcefully blink, thoughtfully blink your eyes. That's a problem. You have any comments about that?
No, I agree. The challenge is always, I think, when you inject in that central location of the upper eyelid, the concern is that you're way more likely to have an induced droopy lid. So I've had that happen to me several times, and then I'm always a little more hesitant. But absolutely, making the toxin more concentrated helps to reduce that risk.
All right, and then there were a couple questions, and I'll open this up. Dr. Schrock might be the one to help with this, is using systemic medications like Klonopin for eyelid spasms. Do you have any comments on that?
So it's with its risks, benefits can be helpful in some people, but it's also risky. People who have blepharospasm are older. It causes side effects of memory difficulty, increased risk of falls. I do have some people in whom the blepharospasm is so severe, and we do teeny little doses of it. Other systemic, but in general, Botox is really the treatment of choice. In my experience, a large majority of people with blepharospasm, you can get a very good result with Botox.
I just wanted to add, we keep talking about Botox because that was the first toxin that we used, but there are other toxins as well. And with respect to our sponsors, I want to make sure that you understand that we're using Botox as a generic term, and that's just our bad behavior.
Yeah, it's much easier to say.
Does anybody else have any
Fine.
comments on systemic medications at all? All right, the next question, kind of follow-up, and is the use of medical marijuana, I guess, or otherwise, as a treatment for blepharospasm. Ali, do you want to comment? I know we've started, since we've had medical marijuana here in Minnesota for about a year to 2 years or so, we have started experimenting with it, I guess I would say, to some extent in patients with blepharospasm. I don't know, Ali, what's your experience with it?
Yeah, so I think three of us here, Andy, Colin, and I, are part of a trial. It was a small trial. We don't have a lot of numbers, but we had some patients who decided they would like to try it. And the way we were able to make it work was, one of the approved conditions was muscle spasms, such as in the setting of multiple sclerosis and other conditions. And I think our numbers are too limited to give definitive results. Some people loved it. Some people had to actually stop it because of side effects. But I think the verdict is still pending. We don't have the numbers to give. Yeah.
So the question was, are we talking just pure oil CBD? So the way it works in Minnesota is we are not the prescribers. We can just attest if somebody has a condition that medical marijuana would be useful for, and then there's prescribers in the community that do the prescribing, and usually what they do is some combination of CBD, THC. We don't have any input into that. I think partially that's why we're at a little disadvantage, since we can't control. And those are the two main active compounds in marijuana. One, the CBD tends to be more active against the muscle spasms, and THC is the part that kind of gets people high to some extent. So it's trying to balance those and the risks. And you can get, like you said, 100% CBD oil, and that is available, I think, at some of the health food stores as well, off the shelf, which is kind of interesting.
So I just wanted to say a comment. I know of no patients in Texas that are using CBD oil because it's illegal in Texas. But of the patients that I don't know who are using CBD oil in Texas, it is profoundly effective, I've seen, in patients who have severe autoimmune disease. And if your dry eye is due to autoimmune disease, and that's contributing to your blepharospasm, I think that if you live in a state that allows CBD, you might think about trying it.
And maybe that's what we should be looking at more than the spasms, is the dryness. And then as a couple follow-up questions about dry eyes, Charlie, I think this was a good question. How do I know if my dry eye would improve with Restasis or Xiidra? Is there a way to test for inflammation?
So pretty much everybody who has dry eye has some degree of inflammation. Sort of a poor man's trial would be a trial of corticosteroids, so a steroid drop. These other drops work in a little bit different fashion, and so it's not a pure test. But if you tried a corticosteroid for a week and you said, I'm really a lot better with this, then I think it would definitely be worth trying one of these other immunosuppressants, they're called, either Xiidra or cyclosporin. And the other point I'd like to make is that the cyclosporin drop, they did a big study in Europe where they looked at the vehicle that carries the cyclosporin versus the full drop with the cyclosporin. And in patients who did not have an autoimmune disease, they found that the vehicle alone was much more effective. They didn't publish that data on purpose, You can find it if you really hunt for it, but it's not well advertised. And that vehicle is available called Retain.
And then just to follow up, Charlie, since you got the microphone, there were several questions about eye rinse. How do you rinse your eye? What eye rinse to use?
So you can buy an eye washer and eye rinse, and Walgreens, CVS, everybody has their own eye rinse. And it's a little bit bigger bottle. It's about 3-4 times the size of a lubricant. And it doesn't matter which one you use. They're basically salt water. And if you want to, you can use an eye cup. Or if you're brave, you just pull your eyelids open and squirt it across your eye. And I think it makes a big difference whether you rinse your eye first before you put your tear supplements in.
Then there was a question about Mage syndrome. What is the best treatment for Mage, and does Botox in the lower face work? I don't know if, Colin, do you want to start with that?
I've never injected the lower face, actually, so I don't know. Maybe, can I punt it over to you?
You can punt.
Yeah, so typically we do botulinum toxin injections, but certain types of jaw movements are more difficult. So we can, for jaw closing, it's quite effective and easy to do. It is more complicated, but it can be effective for jaw opening. But the approach, you can do a couple different approaches, intraoral, or I typically do externally through the fossa here for a lateral pterygoid for opening. But it can be tricky. And then when you have tongue involvement, I mean, I have a handful of patients who have a prominent lingual involvement, lingual dystonia, who have effective, but you have to do it in very, very careful, thoughtful ways to avoid swallowing difficulty with that. Then usually, in my experience, ENT or ear, nose, and throat specialists will do we're talking within botulinum toxin, on a botulinum toxin type A, which is called Botox. You'd use half of a unit in a vocal cord. And it can be very effective, but people can go through a period of having difficulty with their voice and whatnot. I don't know your experience. Oromandibular, I think, is the hardest.
Mm-hmm. A couple of little comments. One is, if you can't get your approval for Botox for that reason, you can get it for something called bruxism, which is grinding of the teeth. And really you're injecting sort of the same area, and so that might be a little trick that you can use. Your insurance company may cover bruxism rather than other facial injections. The other comment I wanted to make is there was a comment made before about how it can sometimes affect your breathing. And that's terrifying for patients that have these dystonias. I'm having trouble with my breathing. Am I going to die? Am I going to asphyxiate? Remember, blepharospasm goes away when you fall asleep. If you have such profound spasm that you can't breathe, when you pass out, it will stop. Nobody dies from this dystonia. That's important because there are people who have tremendous fear about this happening.
That's a good point.
As well?
I think I'm going to follow up with one of the other questions, which will be good. We can go down the row. What is the maximum units of Botox A appropriate for blepharospasm, and then what is the effect of too many units of botulinum toxins? Do you guys have a maximum dose or that you use?
So the most I currently use is I have a patient who uses 450 units of Botox. And it depends on how you respond. I use the dose that people will use. I've got other people that are using 12 units of Botox. So again, I think you tailor the treatment to the problem and to the patient's response.
Colin?
I think Dr. Supercar has a lot more experience, more years on me. I have not had to exceed 100 units, and that's been successful in almost everyone.
Ali, same.
Yeah, very similar. I've gone a little over 100 units, never several hundred units. But my understanding is they use much higher doses for treatment of other conditions, particularly in neurology. So perhaps you have comments on what is the safe maximum dose.
Oh, yeah. In my experience, there's a listed suggested maximum, and I'm assuming we're talking about Botox here. But we can go. I mean, I have injected in a very complex patient in whom we couldn't get deep brain stimulation approved to treat. I've gone up to 1,000 units, but that's neck, an arm, a foot, you know. But never gone over 100 around the eyes, for sure.
And then what is the effect of too many units of botulinum toxins?
So, I mean, a lot of times it is kind of a trial and error thing. We all kind of have a typical pattern that's in our mind, and then we adjust it to what we see in each patient. And I think Dr. Soparker talked about, you know, if you have too much dry eye during the effective period, that's kind of the effect of too much botulinum toxin, perhaps in the right place, and then occasionally you can get a droopy eyelid, double vision around the eyes, and that can tell you either to change the placement of the toxin or decrease the dosage. So, toxin weakens the muscle, so anything, reduced squeezing would result in dry eye, or if it goes in the wrong place, a droopy eyelid.
And in most instances, I think these localized over effects are going to be reversible. In almost all instances, it's going to go away just like the effect would, the normal effect. So I generally counsel patients, it's exceptionally rare because I do see a fair number of double vision after Botox because I'm a double vision guy and everyone gets sent to me. So it almost always goes away in 2 to 3 months.
All right, I think we're going to end our first Q&A section there. We're going to do another one after lunch.